Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. Our guest today is Alicia Faust, Principal at Forivs Mazars. Welcome to the show. It's great to have you here. I will tell you that a lot of your colleagues have bragged about you so much that we finally had to get this thing set up. Every time I'm around any of your leaders with Forivs Mazars, it's always about, JJ, you got to get her on. You got to get her on your podcast. And you've done some work, obviously, around the Hillsdale space, so you do know a little bit about our hospital. But it is so great to have you on our podcast today. So first of all, I want to welcome you to the podcast. It's exciting to have you here.
Well, thank you. I appreciate it. I paid them really well. So I'm glad to hear that my investment is paying off.
Yeah, well, Kevin's going to get his $20 then out of that one. Well, that's
For
great.
Sure.
Exactly. So for our listeners today, why don't you give us a little bit about your background, what brought you to Forivs Mazars, and then beyond that, what do you do as a day-to-day job to impact the lives of CEOs like me?
Well, I came to Forivs Mazars probably about 4 years ago. I'm what they fondly call a boomerang. So I started my career in consulting. I always tell folks I kind of grew up in consulting. And then life had other plans and I went into industry. I started a family. I went to the local hospital association here in the Chicagoland area and then to a large academic medical center where I supported their revenue integrity focus. But consulting's just always been in my DNA. It's what I enjoy. It's what I love. And I chose Forivs because they showed me that they were investing in healthcare. They were investing in their people and their communities. And so the decision was actually quite easy once I made the determination that I would be boomeranging back into consulting.
Yeah. So a great organization.
Yes.
Obviously, you have so many service lines within your organization. I mean, we have auditors. That's how we first were introduced to your consulting arm, is our auditing firm actually is Forivs Mazars. And it's okay. We just refer to it as Forivs, okay? So Forivs is here. And they said one day when I was complaining about, wow, how are hospitals going to make it? You know, you have all these cost structures, you got all these silos, government's taking away money. And our account rep at that time said, well, you know, we have an arm of Forivs Mazars that comes in and consults with hospitals and looks at everything from your revenue cycle management to, you know, your staffing analysis. And so we did that. And we had a comprehensive overview, which you, I believe, were introduced through that process to Hillsdale. At least I heard your name used often while they were here. And so it's great to have, and we'll talk a little bit more about what your company does and what the value add is back to CEOs and hospitals like mine. But before we do that, Alicia, I want to take a moment for those listeners who may not know you. We like to do this little fun part of our podcast, which is a fun and interesting fact about yourself that can humanize you to our listeners in Washington, across this country. Humanize yourself. What's a fun, interesting fact?
So I will say I grew up internationally in Belize, which is a tiny little country in Central America.
Yes.
I was educated in the South in the U.S., and I've lived in the North in Chicagoland area for the last 26 years. And my claim to fame is I won the lottery by having twins.
Oh, nice. Congratulations. Now, so you had twins?
Yes, 15.
15.
Girls.
Wow, good for you. Congratulations. That is like winning the lottery, isn't it?
It is.
It's incredible. Yeah. So Belize, I have a friend that is a missionary in Belize, but I think it's like better weather than Michigan's getting right now, isn't it?
It's better weather all year round, and I'm usually good until about March. And then I'm like, why did I come here again?
Exactly. Well, that is a great fact, and it's great to get to know you just a little bit more. And I do look forward to our discussion today. And what we know is many hospitals and healthcare organizations, including providers, struggle to make financial and operational processes work in ways that support the best interest of the organization and the patients that they serve while remaining compliant, ensuring that their organization is competitive in nature, making sure that they're hiring the best people, and making sure that their workforce production is at the highest level. So in this episode, we're excited that Alicia will be guiding us through her recommendations for rural hospitals navigating these challenges. And there's never been a shortage of challenges today for what we're facing, what has happened with the One Big Beautiful Bill, and what has happened across this country to really dismantle rural health. But the beauty of it is companies like Forivs Mazars is actually there to help prop up hospitals. And you did a remarkable job for us to help us remain viable and sustainable into the future. But I'm excited to have you on the show, and we'll talk about price transparency, clinical documentation. Of course, what does all of this have to do with rural health? So let's get started with something that it's kind of in the background. When you go get your doctor's appointment set up, you're not, as a consumer, hearing the words price transparency. All right. But in the background, administrators, hospital executives, small businesses that are independent practices are talking about price transparency. Can you explain why this matters so our audience gain just a little bit more of an understanding? And then what is changing the reporting requirements regarding the reimbursements for hospitals?
Well, it matters because it is first and foremost a regulatory compliance requirement, right? It is not just a check the box exercise. It is something that we will be measured against. There are penalties attached to it. And the data really does need to be accurate. It also supports what we're seeing in the industry from a transparency perspective, from a consumerism perspective. Whether or not we believe patients are accessing our MRFs, we know they're accessing other areas in order to get those price comparisons for those commodity services. In addition to that, I will say, a lot of organizations across the country have been laxed about it. And we're here to say that this is not the time to do that. So there were a lot of changes that occurred this year. One of the big ones is the Medicare Advantage plans that are now a part of our MRFs. They've always been a part of our price transparency. But what we're seeing is CMS is saying, you know what, we have access to this great data. We're going to add legislation on the cost report side to say you now have to report your allowed amount on your cost report. So not only is your machine readable file a compliance as part of its own regime, but now it's tied to your cost report. Mm-hmm. And the kicker is on the cost report side, it will actually influence your reimbursement starting 2029. So if you've been dragging your feet on whether or not you have all your MA plans listed in your MRF, or the calculation is correct, but we know CMS isn't auditing to the accuracy of the content, just to the template, we're here to say, you really need to take a hard look at that, because this MA reporting is a direct reflection of your machine readable file. And so it is going to become a key part of your future reimbursement if you don't get it right. Not to mention the penalties that you can incur.
Yeah, and the penalties come from the government.
Correct.
And the government regulates a majority of what we do in our business. And when we think about price transparency and the requirement to post charges, there's a word called charge master, right? Mm-hmm. Can you explain to our listener what is a charge master? Because we could have some very entry-level folks that are out there. So what's charge master? What does it mean? And then what do you recommend as best practices regarding hospitals establishing that?
So I always tell folks the charge master is basically your price list. So everything, like you go to a store and you want to buy something, they have an SKU on every shelf and they know what they're pricing at. Your charge master is your price list. You just have an intangible service in the fact that you can't put a label on it, right? Put a sticker with a code. But essentially, that's what it is. I also tell folks that the charge master really does end up driving everything patient revenue related as it relates to a hospital's financial statements. So if it is not on your charge master, guess what? You will never be able to charge for it, which means that revenue is already
Gone.
gone and lost. And so you really need to maintain your price list or your charge master. You have to think about it beyond just the life cycle, or you need to think about it in the life cycle of the charge master. Most people only think about their charge master at the end of the year or at the start of their new fiscal year when they're tying it into budget and saying, I'm going to put a X% across the board increase, or I'm going to do something strategic, or I have to be compliant with all of the changes that CMS has put out as part of their October release for January effective dates. But we say the charge master has a life cycle. Is that the most critical component? Probably. It's where the heaviest lifts occur. However, CMS as well as private payers and commercial payers are making changes to coding all year. And so the life cycle is really on a quarterly basis. You really need to be looking at that and ensuring that it's reflected, all the codes and all of
Mm-hmm.
the services that you're providing in regard to how the payers are actually going to receive them and pay for them.
Mm-hmm.
So it really does drive the patient revenue, and it is tied to everything else that you do downstream. So education is key. Engagement in the charge master with your clinical departments is key, because if you're not having those integrated conversations with your clinical departments, your charge master or your price list is still not going to reflect all of the good work and services that you're doing. So it's a key component of driving your business. It ties into charge capture. It ties into clinical documentation. It drives into financial impacts as it relates to your payers, and the actual impact of your contracts and how you set your prices. So the charge master is kind of the heartbeat of everything that you do
It is.
downstream.
It sure is. So let's take it a step further. All right. In context of the charge master and all of that work that goes on in the background, what does Forivs Mazars provide to organizations, hospitals in that environment? Do you get them ready? Do you audit it? What do you do?
So we do a combination of things. We focus on the revenue integrity or the middle revenue cycle. So what that means is that we look at your charge master from a compliance perspective. We're making sure that you have the most updated CPT codes, HCPCS codes, Rev codes, modifiers that CMS and the payers want. But we are also working with your clinical departments to understand what's happening in those clinical workflows and that it's reflected in your charge master. And then we do a lot of education around it. So we do chart audits, and so we understand how folks are interpreting these codes, because the codes also come with meaning and application as it relates to the service being provided. So we are able to provide education to our clinicians, education to coders, to ensure that they're maximizing reimbursement and capturing everything that's occurring in that clinical workflow. It is an integrated process between your revenue integrity, your finance folks, and your clinicians.
Everywhere I go, I hear hospital executives talk about the burden of backroom function for denials and denials management. It's a huge, huge lift for hospitals, peer-to-peer, all of the requirements and authorizations, pre-authorizations. In that world is looking uglier for us than it's ever looked before. It's not getting any easier, is it?
No, not at all.
Talk to us a little bit about that relationship. What needs to happen to improve that alignment between the payers and then what we're seeing in the reality of those denials, and how do we bridge that with those variances?
So I would say a lot of organizations don't really look at denials on a aggregate level. They're really trying to identify kind of that one large claim or that one item that pops to their attention. But you really need to look at your denials in totality, and you need to tie it back to your payments and what you're receiving. So as we move more and more into the world of AI, we know the payers are using it, right? We may or may not be as sophisticated. We may or may not be able to keep up with the technology that they're using. But we do have resources to be able to help support those denials. And a huge
Mm-hmm.
part of that is creating your denials committee, where on a monthly basis, you are looking at what you're getting back. And
Mm-hmm.
you're working with your payers, you're engaging with your payers earlier. I know it's tough. The payers, they don't even want to answer their phones and talk to us when it's time to negotiate.
It's true.
But we have more to lose, right? So we have to do everything we can to get them to the table in order to look at those denials. You also need to break it up into major buckets and bite-sized chunks. So what can I fix on my front end to be able to minimize my registration denials, right?
Mm-hmm.
That we fully control that. How do we put processes in place and checks and balances in order to support that? When
Mm-hmm.
we get to the authorization phase, do we have the right people? Do we have the right contacts? Are we authorizing the right things? Are we keeping
Mm-hmm.
up with all of the payer changes that they're
Mm-hmm.
making? Because today this requires a not, tomorrow it does not. And if we're not monitoring those websites, then we're playing catch up after the denial came in. We have to shift our thinking to preventive denial versus reactive denial. And
Mm-hmm.
again, prior authorization is one of those ones where we have control and can really support that.
Mm-hmm.
Now, the other part of denials we call the silent denial is the payment variance side of it.
Mm-hmm.
So, yeah, I did get paid. I got paid my DRG for that inpatient claim, or I did get paid an ED level for that ED visit, but did they downgrade me? That's also a denial, right? Because they are
Mm-hmm.
not paying us for the work and the services that we provided based on, I don't want to say arbitrary, but based on their rules, based on their regulations. And so a lot of organizations, especially small rural ones, think they have to have really sophisticated software in order to monitor these denials. You can keep it really simple and just look at your top 25 DRGs, the
Yeah.
ones that you're doing the most volume on, the ones that you know are the highest cost to your organizations, and really monitor those to ensure, are you having line item denials that you can actually go back to the payer and appeal? Are you having authorization issues that you know you can manage and put processes in place? And you're reconciling that back to your contract to say, I'm getting every penny that I'm due that I've negotiated. The other part of denials is what we're seeing with the payment variances is payers are getting more and more creative. So not only are they denying based on the use of the code, the compliant use of that code or that CPT that's tied to your charge master, they are also saying, you know what, we're going to circumvent your contract and we're going to change our payer policy. Nobody's monitoring the payer policy, and all of a sudden you get hit with a bunch of denials because, again, we're being reactive to wait for the payers. So the payers are always a step ahead of us.
Mm-hmm.
My advice to rural organizations and organizations of any size is you've got to create some accountability within your organization for folks monitoring those payers. And if
Mm-hmm.
you're not going to get physical engagement with them, you got to at least get virtual engagement. You've got to be monitoring and trolling their websites to see what they're changing, what outputs are they putting out there, so that you can continue to manage those denials. And the key is to shift it from reactive to preventive.
Yeah.
If you can manage the preventive side of it, then the reactive side becomes manageable, right? Because now it's one offs. Even though the one offs might be something new every day, you're at least keeping up. You're not falling as far behind as if you're just completely reactive.
So someone's listening to this today and they're going, OMG, that's a lot. I mean, these are a lot of moving parts. We don't have the bandwidth to do this. We don't have the manpower. That's where Forivs Mazars, you can have an opportunity to speak with an executive, give a proposal, and then you get involved in helping the process. Talk to us a little bit about what that looks like, an engagement to improve some of these areas.
Sure. So we have invested in technology where we can actually ingest your 835s and your 837 files on a mass scale. And then we have created and developed dashboards that are really simple reporting that most organizations don't have. You're able to track your denials by denial code. You're now able to tie dollars and count to those denials. So now you're focused on the right things as it relates to those denials, right? You're not chasing that $10 denial. You're really chasing the 50 claims that equate to 15% of your revenue or denials for that month. And then you're moving that. We always say that we go people, process, technology. So if technology can help us, we can give you tricks or tips within your EMR in order to support that. We do a lot of education, a lot of at the elbow support with the different denial areas in order to support better registration, better prior authorization, better clinical documentation, all of it in an effort to reduce those denials. And we're able to trend it because we get that ongoing feed of those 835s. You also have the advantage of all of the denials that we're seeing at the payer level across the country. And so rather than living in kind of your microcosm, you're now able to look at it from a much bigger picture. And so that's where I think rural organizations can really value and get benefit from Forivs Mazars in the denial space. And that's one side of our practice. We have a whole other team that does nothing but payment variance. So they take those same 835s, 837s at the claim level, and they apply it to your contracts. We have strong contract management software where we can model for you, did you get paid appropriately? And again, we're not talking about boiling the ocean. We're applying the 80-20 rule and focusing where the dollars are being missed.
And certainly have been significant value to Hillsdale Hospital in the terms of millions of dollars of improvement to our bottom line due to the work that Forivs Mazars has been engaged in this exact area. So, Alicia, one of the things we're hearing about today is something called CDI. Now, it's been in the background for years, and I remember about 10 years ago being brought into meetings and hearing the CDI, clinical documentation improvement. Clinical documentation improvement. What is it all about? Why is it important? And what can hospitals do to strengthen this?
So the first thing I'm going to do is bring you to today's lingo. CDI now represents clinical documentation integrity.
Integrity,
right?
There we go.
It ties into the middle of the revenue cycle, which is revenue integrity. So clinical documentation is, and these are not my words, but they're probably the most famous words as it relates to CDI. If it's not documented, it didn't happen, right?
True.
It seems super simple. And so what we talk to clients and engage with them on is if you've got automated clinical workflows in your EMRs that you can automate. Try to do as much of that as you can. But if it has to be manual, then you have to be at the elbow with your clinicians. And the words are educate, right? Have those ongoing communications with them in any clinical space, whether it's inpatient or outpatient. Ask them what they're doing in these services. Understand all of the nuances of what they're doing clinically. And show them that even the most minute or minuscule piece of documentation that they tell you but wasn't in the chart could mean the difference between a higher DRG and a higher ED level on the outpatient side. And the docs just don't think that way, right? They think in major processes. I removed a lesion. Okay, but you removed a lesion of what? Half an inch, 3 inches. Depending on CMS, you might have a different CPT code for every single one of those. They each pay differently. And you could be leaving dollars on the table because we have to document to the most conservative level, right? So it's getting the clinicians to understand that no matter how minor the detail or how painful it might seem, please add it to the chart. It's better to have more than less.
That's right. So this podcast is dedicated really to focusing on rural health and the challenges associated. Typically in rural health, we find that the bench strength isn't very deep in rural hospitals. Many of us are engaged in 4 or 5 positions in one. And so there's a lot of challenges. And right now, there's so much being thrown at us. When we look at just revenue, cycle, integrity, CDI, all of those things, there's a lot of work. And so I want to ask you, as our rural partners are listening across the country, what are the primary gaps in rural health regarding all of these things we've talked about? Charge code, price transparency, payer negotiations. And then at the end of the day, the $1 million question is with limited staff and resources. How do rural hospitals pull all this off? What's available for them?
So I will tell you, we see it across the country, large organizations as well as rural, but rural is at a definite deficit when it comes to the talent pool, right?
Mm-hmm.
And the ability to recruit. I will tell you, you have to lean into that virtual or remote workforce. It's not the most popular answer with rural hospitals, but I will tell you that later this afternoon, I'm going to be speaking to a client. They're situated and located, their main campus is in Tennessee. I'm talking to their revenue integrity folks to talk about pricing, to talk about charge master and clinical documentation. Three different folks in those leadership positions, they are all in three different states.
Mm.
So if you really are looking to invest in that talent pool, while it might not be available locally and you're struggling to get folks to move to your area, really lean into those remote workforce. You'd be surprised what you can get accomplished, right? In addition to that, I would say lean into your vendors. I think a lot of times what we see when we go to rural hospitals, they have these really great contracts, but they're so busy with patient throughput, to your point, wearing multiple hats, and everybody forgets about the contract after you've kind of launched and gone live with whatever vendor it is. But if your vendors are coming in on the GPO side for supplies and pharmacy, and they want to provide you with a new supply or pharmaceutical, it's great. But help me understand that. Am I going to get paid for it? What's the managed care ramifications? How much is it going to cost? What is the patient efficacy? Lean into your vendor. If you've got an EMR, or if you've got a payment variance tool, or you've got a clearinghouse, or you've got coders that are outsourced, all of them might actually in your contract have education hours that you can use on an annual basis. I can't tell you how many hours go unused where it's part of these contracts and folks never action against it. And that's a way to engage with your vendors to optimize whatever tool you bought from them, while also not having to incur additional expenses. And then the last thing I would say is, really follow those websites. Designate somebody on your team to sign up to CMS, to sign up to every single one of your pairs. And while it might be email overload, you'll be surprised at the cadence that you can get into just to stay ahead or to stay up with what's happening in the industry.
And just to note, though, let's say an organization is like, we can't do that. Forivs Mazars provides wraparound services, correct, to help and consult to provide that information as in real time and ongoing. Is that correct?
Correct. So we do provide education. We have ongoing education that we do in different areas. You just need to go to our website. One of the easiest things that you can do is we do have a podcast ourselves called Achieving Health. Chad Mulvaney is very well respected in the industry, and it's able to give you really good regulatory updates on a pretty frequent basis. In addition to that, I mean, if you can think about a component of it, with the exception of true IT build, Forivs Mazars probably has an opportunity or a service that can help you in some way.
Alicia Faust, great to have you on the podcast today. I'm sure this is going to be one of many discussions that we're going to have now and into the future about the ever-changing world of healthcare reimbursement, documentation, throughput. And the beauty of it is that your company, you're cutting edge. You bring the best and the brightest in industry, and you're providing real life experienced people and you're infusing them into communities like Hillsdale to give us state-of-the-art understanding of how all these processes work. And I'm telling you, it's been incredible for Hillsdale. It has been an incredible relationship just beyond, our accounting firm to really look at it from a different lens. And we had to make some sustainable changes, but it's great to know that there's companies like yours, Forivs Mazars, out there helping protect hospitals, because at the end of the day, this is all done towards an eye of making sure that our rural hospitals remain open and viable. That's the primary goal.
Yes, our firm is committed to healthcare. We are committed to the rural organizations in our country. We're committed to our communities. we live in some of those communities, right? We're not all urban folks. And so we are very proud of our mission, which is to help hospitals support and achieve their mission.
Alicia, we have many new leaders that listen to this podcast. I get emails all the time about how a segment, an episode, a series has transformed or improved their lives in leadership. And so one of the things that we thought when we rebranded our podcast was to ask our experts like you. You've been in the industry. You work around national healthcare organizations, small organizations, everything in between. There's a lot of turnover that's occurred in the last decade. And then post-pandemic, there's certainly been a lot of turnover in the C-suite. And so we have a lot of new leaders around the country in healthcare. And so what we like to end our podcast with is called Rural Health Recommendations. And we run these separate. But it's really your sage advice, a tip, some wisdom based on your years of experience. You've been in the field, you've been in the trenches. What recommendation, piece of advice, sage advice, wisdom, whatever it is, would you give a new leader today rising up in healthcare about how to sustain themselves, how to focus? What would that look like from your perspective?
I absolutely love that question. So I coach all of my advisees that come in that are usually new to consulting or new to healthcare altogether. And my only advice is get involved and get involved locally, whether that is your local HFMA, your local ACHE, your local AHIMA, whatever area of healthcare that you want to support, get involved, go in person. Yes, virtual is great. Yes, you can participate, but you can never underestimate the value of those connections that you make. And if nothing else, you get to meet your peers and you get to understand that you're not going it alone, right? That they're experiencing the same things. And whether rural or urban or large or small, critical access or PPS, you're all dealing with the same issues, right? It's just the scale that we're dealing with them. And so to have that peer that you can pick up the phone and talk to confidentially about here's what's occurring within our organization. Are you experiencing the same thing? How are you solving it? Get involved locally. And then those same organizations are going to have virtual boards. Follow those boards. You'd be shocked at the communications and the knowledge share that takes place there. Not only from just local folks in your hospitals in the area, but really some of these large consulting firms are on those boards as well, providing advice to you just by reaching out and asking the question. Get involved.
You heard it here. Get involved. Absolutely love it. Some sage advice, and certainly have followed. Individuals can be an absolute firestorm for their local community hospitals and healthcare, and then migrate to the state or even the federal level with that same messaging, knowing that you're representing rules. So, you know what? It's been great to have you on the podcast today. I look forward to many more conversations about these. And some people don't think it's exciting. I do. I think if we can improve a hospital's bottom line, we can save jobs, which means if we save jobs and we save a hospital, we save lives. Don't ever think for a minute that the work that you do each and every day to help hospitals like ours, Alicia, don't ever think that it doesn't go unnoticed, because patients are still able to walk through those doors because of the work you've done.
Well, thank you. We appreciate that. And thank you for having me on the podcast.
It's been great to have you. And thank you to our listeners for tuning into Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.